All right, we'll go ahead and get the second session started. The title of the second session is Screening and Eradication of H. pylori, an Opportunity for Prevention. Again, I'm Hwang, and then my co-moderator here is Professor Khay Yeoh from National University of Singapore. The first talk will be given by Shria Kumar from the University of Miami. Is she here? Oh, there she is. We met 1 or 2 years ago at DDW, and I actually had the pleasure of reviewing her manuscript that came out. I don't know if you knew. But
were you the one that rejected it? Or
no, I was the one that accepted it
Perfect.
right away. So she's going to be speaking to us on community-based testing and treatment for H. pylori, which I think her approach to this is just beautiful and is very pragmatic. And so please welcome Shria.
Thank you so much. I appreciate the opportunity to be here and to speak with everyone. So I think, I certainly don't need to tell this group about H. pylori and its role in gastric cancer, but this is really where this idea came from. We know that H. pylori is a causative agent in gastric cancer, and we have really pretty good data that primary prevention works. We see that in Korea, randomizing people who with a first-degree family member to H. pylori treatment or not reduced gastric cancer incidence, that there is a difference between having persistent infection and eradicated infection. We saw in the Matsu Islands, 6 rounds of mass screening and eradication resulted in a decrease in gastric cancer incidence and mortality. And we saw in China that randomizing people to placebo or H. pylori treatment reduced gastric cancer incidence. And more recently, we've seen that compared to symptomatic control, there's a smaller but still persistent decrease in gastric cancer incidence. We also know that the US has similar findings. And this is important because when we talk about this environmentally driven cancer, it's important to not just simply extrapolate and say that's sufficient. So this is a study from a few years ago that we did in the Veterans Health Association. We found almost 400,000 people with H. pylori diagnosis, and we looked at their future gastric cancer incidence. We found that, yes, eradication reduced gastric cancer risk, and importantly, it was eradication. It wasn't just giving the treatment, it was having confirmed eradication. So really that 3-step process that's still emphasized in the guidelines remains important. So we know H. pylori eradication reduces gastric cancer risk, but we also know there are no programmatic strategies in the US. And when I think critically about this, I would say there are a few reasons for this. Number one, there is a low incidence of gastric cancer. There are potential harms of overscreening. We do live in a resource-confined healthcare system. And there is lack of evidence regarding esophageal cancer mortality and its sort of sister upper GI cancer. And it's also important to acknowledge that most people with H. pylori will never develop gastric cancer. And we don't really know among everyone with H. pylori who will develop it. We don't know how to best risk stratify. And we do want to avoid over-testing, over-treating, and any potential incidental harms. And I think these are pretty reasonable arguments, but I also have a few rebuttals when I have this conversation with myself out loud or in my head. The first is that gastric cancer is a cancer of disparities. We all know that there's a higher incidence among Asian Americans, Hispanic Americans, African Americans, certain immigrants, and Native populations. And this phrase actually came from a different healthcare outcome, but I think it's really apt in gastric cancer. And as was sort of being discussed yesterday, this feeling that we can do nothing feels stagnant. And I think it's true, and I think it really is the ideal condition to elucidate the hidden costs of inaction because there's a higher mortality, a higher burden that certain minority groups have to shoulder. And unfortunately, gastric cancer is underfunded. So we did this study where we looked at funding to lethality ratios. So lethality is a measure that takes into account incidence rate, mortality rate, and person years of life loss. So it really accounts for public health burden. And what you can see here is that compared to breast cancer, there's a 100-fold difference decrease to stomach cancer. So it really is underfunded. There's not even a good correlation between funding to lethality and mortality. So when you think about where we're putting our money, you would at least think we should be putting it to the things that really kill people the most, that have the highest mortality, and we're not doing that. And the link is so strong here. I think cervical cancer is the best parallel. So almost all cases of cervical cancer are caused by HPV, but you can really edit this quite nicely and say the same thing for H. pylori. And just like cervical cancer, I think there's a value in looking at what's happened there. So in 2000, the incidence rate of cervical cancer was 9.5 per 100,000. And if you look at the absolute numbers, it's also a relatively rare cancer. And in the last 20 years, we've reduced that incidence rate. I think the other thing that we don't look at enough is that there are potential impacts other than gastric cancer when we think about eradicating H. pylori. There are 2 studies that have looked at this, and someone mentioned some of these. But in another low-incidence country, the United Kingdom, they randomized people to H. pylori treatment versus placebo, and they found that a 10-year follow-up actually showed cost savings. And those cost savings were more than the HP testing and treatment alone, because people utilized healthcare resources less. And I think in the US, that $117 would be significantly more. In another study out of the United Kingdom, they randomized persons to H. pylori treatment or placebo, and just in 2 years, they saw a reduction in primary care visits for dyspepsia, and people have a decrease in who actually had regular symptoms. And again, when you think about the burden of GI cancers and benign GI disease in the US, you can imagine how important this could be. So, back to cancer. This slide has been shown a lot, and I really focus on this because I think it just kind of exemplifies how much we don't know, because if the guideline had enough information to be more discrete and more granular, it would have been. And when you think about, okay, if people who are racial and ethnic minorities are at higher risk, it's a lot of people. It's almost, we call them minorities, but it's 50%, just under 50% of the US population. And when you think about this number, you cannot reasonably subject 140 million people to H. pylori eradication because that involves testing, treatment, and retesting. All of those have cost. Treatment, unfortunately, has side effects. There are unknown side effects, antibiotic resistance, and so forth, but there's also pretty discrete side effects. We've shown that there's a 1% risk of C. diff in those people. So you can't really just say, okay, all of these people are at risk for gastric cancer, and therefore we're going to eradicate their H. pylori. On the other hand, I don't know that you can test by race and ethnicity alone. Dr. Shah showed this really nice paper where there are geographic differences, and even among non-Hispanic whites, there are geographic differences. And without knowing much about Toby Keith, he did have gastric cancer, and you want to think about a programmatic strategy that's inclusive. So the second thing I think is an issue with this is that these groups are very, very heterogeneous. And this has been talked about before in terms of disaggregating. And I think it's really important. So everyone in this group could be considered Hispanic or Latino, but we know that they don't all have the same gastric cancer risk. And we looked at this with country of birth and gastric intestinal metaplasia. So I'm at the University of Miami. We obviously are really well represented in terms of Hispanic and Latino countries. And in the last 10 or so years, our EMR has actually asked for country of origin or country of birth. And it's a self-reported measure, but it's pretty good. We only have about 20% missingness, and we have a lot of diversity. So what we did is we looked at everyone who had undergone an endoscopy with biopsy. We looked at their GIM prevalence, and first we just looked at race and ethnicity. And as you would expect, it's highest among Hispanic Blacks, non-Hispanic Blacks, and then Hispanic whites. But in our multivariable model, we actually included country of birth. And these are the adjusted odds of having GIM by country of birth. And what you can see is that not every country in South America or Central America is the same. And even neighboring countries can have very disparate rates. And this sort of mimics what we already know, but it just shows that in the US, we don't have the granular data sources to look at this, even though it's really important. So I guess what do we do then? Do we look at everyone individually? Do we build risk scores, which I, in my epidemiology training, would think is great and super exciting. But I think the problem with that is that there are a lot of unknowns. And the other thing is that there are a lot of barriers to risk scores. You need to visit a clinician. The clinician that you visit needs to know about this risk score, And there has to be sort of a two-way street with communication. And so when we think about which groups are impacted by gastric cancer and H. pylori the most, you can see how people would get left behind if you just left this to risk scores. So we posited an enclave-based approach. So in South Florida, we have a really high burden of gastric cancer, sort of reflective of the demographics. And we said we are going to try a community-based approach. So we thought about this a lot, and what we essentially do is we go out into the community. These are some of our team members. We take this portable 14C breath testing machine, and we go out and we test people. It's a research study. We ask for informed consent. We test them on the spot. If they're positive on the spot, we give them medications, and then we arrange their retesting. We recruit from various places. There are health fairs, community sites. Our cancer center has a mobile game changer vehicle that goes around, and we really just try to target any location that's willing to work with us that is in our catchment area. Of course, people have to provide informed consent, and we, of course, have exclusion criteria. The 14C pill is radio-labeled, so people who are pregnant, nursing, planning to become pregnant, they have to be able to take the medications, and we only provide the bismuth-based quadruple. We don't include anyone who was previously tested or treated for H. pylori, but we have found pretty good motivation. And then the last thing that we do is everything is free of charge. So this is completely free, and as I said, we give them medications on the spot. We don't tell them to go to the pharmacy. So we published our preliminary data, and thank you again, Juha. So we did 36 sessions. We tested 155 participants. Again, small sample sizes, but we have 34% infection. As you would expect, people with infection are more likely to be Hispanic or Latino. They're more likely to be non-English speakers, and they're more likely to be born in South or Central America. When we first did this, we were quite excited about it because we thought this showed feasibility. But the more we thought about it, and with some outside advice, we realized actually it wasn't that good, because the only people that would get tested, treated, and retested, the number was actually 42%. So we had a really suboptimal eradication rate. And this was really due to loss to follow-up. People would not take their medications. They would tell us that on the phone, or they just wouldn't return for retesting. We have a rule where we would call them up to 5 times. We would try to do this at different times of the day, at different days, at different weeks. We had a text messaging platform, but we just couldn't get people to return for retesting. And that retesting was sometimes at our clinical center. It was also sometimes at a local center to them. We'd say, we could come to you. And when for the people that we were actually able to speak with, we found that there were a few barriers. The first is medication burden. So we provided 14 days of bismuth-based quadruple therapy. And this was alluded to yesterday, but it is really difficult to take. And when we have been packaging these, it doesn't come in a blister pack. It is almost 200 pills. And when you bring it out and you hand it to patients, they're just, oh my God, their eyes go wide. And it's really difficult for them to take it. The second is that the need to return for a second appointment is really prohibitive. And it's particularly prohibitive for people that work, that have difficulty taking time off of work, that might have transportation issues. But we did also find facilitators, people who had family members with gastric cancer, or just even knew about the association between H. pylori and gastric cancer, which people in our catchment area really do know about. We're very motivated to undergo testing and to complete the treatment. So, while this was a feasible community-based testing and treating strategy, it wasn't really effective. And while it provides a framework towards the primary prevention of gastric cancer, I think it also highlights some burdens. One of the ones I haven't talked about is it's a really slow process. To do informed consent, to do the testing, to counsel patients, it takes at least 30 minutes per patient. And again, despite us trying to remove barriers, we didn't really get sufficient rates that you would want to say, okay, this is ready for a programmatic strategy. So we did try to be very intentional about this and try to overcome specific barriers. The first was that we really tried to leave clinical confines. We used a mobile platform. We didn't limit it to people who would see me in clinic or be at Jackson at clinic or be in the hospital. We tried to go outside of traditional healthcare settings. We were completely agnostic regarding symptomatic issues. So some people did have GI symptoms and we asked them about it, and some people didn't, but it didn't matter. And we didn't need a clinical indication to have people get tested. Again, we provided the medication free of charge and handed to patients at the time of their test. And we really tried to be linguistically and culturally appropriate. We reached out to every center, we introduced ourselves. This was facilitated initially by and Sylvester's shared resources and CTSI, and then we started building our own relationships. We meet people beforehand, we introduce ourselves to the on-site staff. The on-site staff oftentimes gets tested so they know what they're being involved in or what they're witnessing. And we have a research team that speaks native Spanish, native Haitian Creole, and we really try to make sure that we are linguistically appropriate. And I want to highlight Dr. Aplean's study because I think this was really, really well done. And so this was in 2018, and they did a one-time event at a predominantly African-American church in 2018. And 23 of their 92 participants had H. pylori, 20 of them got treatment, and 14 had eradication. And I think one of the things that I think is best about this study is this table 1. And when I think about how we could do community engagement for H. pylori, I think this is the perfect way to do it. And so I've sort of broken this down, and there are a few things that I'd like to highlight here. The first is that they got input from key stakeholders. They did these separately because you don't want to include health services and community-based researchers with the community. That might be obvious, but you also don't want to include them with the clinicians who are going to ask different questions. And what I also like about how they outlined this is that they took what their initial project ideas were, and they explained how this impacted their future development of the study. They also met their congregation beforehand, introduced the topic personally, and I think this is important. They presented the project as a cancer prevention strategy rather than a focus on disparity. And we found that as well. You know, when we talk about H. pylori transmission and we talk about fecal-oral contamination or poverty or socioeconomic status, it can be really stigmatizing, and it's really important to be careful about the words that we use when we're interfacing with the community. They used a church, and that was important because individuals are comfortable there, and it also provides some flexibility. This was done on a weekend, and we also have found that weekends work much better than weekdays, even though there's so much limitation to what our research team can do. We actually have a strategy now where we have a deal where if the research team goes out on a weekend, they just take off a weekday of their choice, just so we can improve our engagement. We considered stool test, and the DISH study did as well, but it's really a barrier. And there's a lot of cultural stigma against holding stool, carrying stool, and taking stool. So breath test really does seem to be more effective. I think this was really important where they looked at participant reimbursement. And if you've ever tried to do participant reimbursement, you need W-2s, which have a social security number or a taxpayer identification number. And when you're talking about people that might be underserved, disenfranchised in some ways, or even undocumented, you're just not going to capture them if you ask for this. And then I think this one is really important. More than, I would say, my clinical practice, participants in these studies really want to reach out to us, and they really want to hear from us. And the communication is more frequent, and it's more intensive. And I think being cognizant of that and setting up this in such a way that they know they're going to get a phone number that they're going to call and someone is going to pick up. If they're going to text back, we're going to text them back and say, when can you talk? And when we call them back, you know, if it's a Creole speaking person, I don't call them back. The coordinator who speaks Creole calls them back. And then finally, they also did retesting. Importantly, one thing that they did that we are still struggling to do is that they went back to the same place. Again, a congregation tends to be a more stable cohort where they know every Sunday or every few Sundays they're going to be there. And that's, I think, a really big strength of a place of worship testing strategy. And so why is this all important? So I think we all know that engagement can facilitate implementation. So we know this intuitively, and we know this in studies. The Nordic study, where they invited people to undergo screening colonoscopy, only 42% of them underwent screening colonoscopy, and the take-home from the study and on the media was that screening colonoscopy doesn't work. And so many people were said, hold on, hold on, hold on. And of course, that would make sense. You can only be effective if you're uptaking the intervention. Similarly, the study that came out earlier this year, same thing. You're invited to something, but if you don't take the invitation, how could screening ever work? And so while this might seem obvious, and to me the data is pretty clear, primary prevention works, I'm not sure that we're there yet to implement this because I think it would be premature. Suboptimal intention to treat eradication rates of 42% just aren't sufficient. So we really need to develop systems to implement this. Part of that has to be culturally appropriate. What works in Miami will not necessarily work here, will not necessarily work in LA, and will not necessarily work in Durham. We need better risk stratification, and I think we need to be more conscientious of what participants are experiencing. So we need medications that are more tolerable. While we give 14 days of bismuth-based quadruple therapy, I would wonder if 10 days is sufficient, and I would wonder if there's a way to make dosing easier. I think we should also focus on the evaluation of non-cancer benefits of HP eradication, because I think this could improve the utility and the pull of a programmatic strategy. Thank you so much.